Abdominal pain and vomiting for 2 weeks. So Greg GS, 65-year-old male patient with no significant past medical history, no past surgical history, no with gastric cancer. Issues, there was nail issues reported by the patient. Input, he feeds via NG tube and IVF 500 mils NS. Output, NGT drainage, it was coffee brown color, less than 100 mils. Urine, no stool. He passed gas and no vomit. Vomiting. The vomiting was clear in color, and no diarrhea. Medication. He's on cimetidine, injection cimetidine 200 milligram IV, injection morphine 20 milligram IV QID, injection Panadol IV QID, injection ondansetron 4 milligram IV TID, and that was it. Besides the imaging, so imaging showed small amounts of gallstone, mild biliary sludge, an enlarged prostate, and mild free fluid in the abdomen and pelvis. And there was mild pleural effusion seen in the right lung. And the gastric walls appeared thickened. So the impression there, he has cholelithiasis, prostatomegaly, free fluid in the abdomen and pelvis, and right pleural effusion. And yeah.
Okay, so my question is, where does this gastric mass come in?
Yes. On physical exam, it was felt there was a mass in the epigastric region on physical exam.
It's a mass in the epigastric region.
Yeah.
So the image finding that you said just now, that was a CT scan, or?
Yeah, it was a CT.
So the CT didn't see any mass in the stomach?
It just said the gastric walls appeared thickened. It didn't say anything about
Gastric
the mass.
walls appeared.
Yeah.
Alright, what were some of his chief complaints?
Abdominal pain and vomiting for 2 weeks.
And
Vomiting. Yeah.
yeah, and the examination findings, what did you say?
There's a mass in the epigastric region, and
How
there
big
was a lot
was
of
the mass?
significant. I would say about it was like 5 cm.
5 by how much?
Like 3.
3?
Yeah.
You said the CT found
Cholelithiasis, prostatomegaly, mild free fluid in the abdomen and pelvis.
free fluid in.
The abdomen and pelvis. Right pleural effusion, and the gastric walls appeared again.
So, just with this limited information, right? What are some of the more important diagnoses that comes to your mind?
Well, again, there's cholelithiasis here.
No, but I mean, looking at the whole picture, right? Looking at everything. Yeah, I guess gallstones could cause, they do cause rather. Gallstone disease can cause vomiting and abdominal pain.
Could be gastritis with the abdominal pain and the vomiting as well.
So it could be gastritis, right? What else?
Pancreatitis, appendicitis.
It could be pancreatitis, yeah. Well, appendicitis is the appendicitis can mimic any disease, right? It's a great mimicker, right? So, at any point you're thinking like gastric cancer,
Not from the chief complaint.
not from the chief complaints. Okay. Did you ask about? I know you probably didn't ask, but what about B-type symptoms? Constitutional symptoms. Did you get a chance to ask about them?
No.
So what would have been the reason for asking about B-type symptoms?
Well, could be a tumor could potentially cause an obstruction, so he could present with symptoms like constipation.
No, so B-type symptoms are constitutional symptoms, are fever, weight loss, night sweats, right? That's usually a good indication that a patient has malignancy. So when you're having these situations where you're finding a mass or you're thinking this thing is cancer, whether it be an imaging or a physical examination, you should always consider asking B-type symptoms, right? I mean, you can't really rule out gastric cancer, right? The most common form of gastric cancer that you will find is adenocarcinoma, right? But locally here, believe it or not, we see a lot of lymphoma. We see a lot of gastric lymphoma. Right? So that's something to consider. And when you look at the picture with the thickened gastric wall, the diffuse thickened gastric wall, the fever, the vomiting, and I think the residents were telling me that they're thinking more towards it because he was having constitutional symptoms of weight loss over a long period of time, right? It looks more than in the direction. So I think the question now that you already have advanced imaging, you have a CT scan, what is it that you're going to do to progress the management of this patient or the investigation?
You could
Right. So you can do an EGD, right? Which is the endoscope, the esophagogastroduodenoscopy, right? And basically what you're trying to determine is if there's actually changes within the stomach wall. So other than visualization, it gives you another good advantage. You are able to, anybody? Do a biopsy. Right? So you're able to do, excuse me, you're able to do a biopsy with the EGD. You're probably not sure, but did they get to do some, like a H. pylori test or so?
there was no anything about the H. pylori test in the folders.
Okay. So H. pylori testing, it can be helpful, right? So looking at all your diagnoses that your differential that you put down, these two are essentially ruled out, right? And we were able to rule them out because of the CT scan, right? You're not sure if it's gastritis as yet. What was the amylase?
The results didn't come back either. They
So
sent
the
out.
amylase pending. Right? So a high amylase would actually lead to gastritis as well, right? But you can also use your EGD here as well, right? The did the CT say specifically cholelithiasis or cholecystitis?
It said cholelithiasis.
Cholelithiasis. So, in a sense, we have sort of ruled out gallstone disease as being the main factor. So then, which leaves us with the gastric cancer. And from here, we will have to get the endoscopy done in order to plus or minus biopsy in order to move forward or advance our care for our patient. I think it's very important that when you look at these cases, it's not just for you to follow up, but it's for you to put yourself in the position of the physician that managing the patient. Alright? Try to figure out how is it that you are going to get a patient from point A to point B. Point B is discharge, or at least making a diagnosis. Right? So one of the more important things in making your plan is to ensure that you're covering all your bases, is ensure that you're covering all your differential diagnosis in terms of ruling them out or making one specific diagnosis. And you have to continuously think about it. Okay, do I need to go back to the history and take a little more history? Right? I know that I know that you didn't really get a chance to take the full history, but like in the sense of, let's say you did take the full history, then you decided, well, okay, suppose this thing is cancer now, then you go back, you didn't take the constitutional symptoms before, you go back to the patient, you ask him, so sir, were you having like fever, weight loss, night sweats, and these type of things, right? So this is basically to help you have an idea of like, okay, you get a patient, you're uncertain about the symptoms, how to go ahead, get your differential diagnosis, and how to try to investigate them further, right? So you guys have any questions?
Doc, wouldn't testing for tumor markers be helpful?
That's actually a very good point. Yeah, you can actually test for tumor markers. If you have a very high suspicion, you should test for tumor markers, right? You gotta be careful though which interpretation of tumor markers, because a lot of tumor markers are not diagnostic in nature, but it's just merely to follow up the progress of the patient, right? So that's something to really consider.
Could inflammatory bowel disease also be considered?
Hmm?
Inflammatory bowel disease, can it be considered as well?
Yeah, definitely inflammatory bowel disease can be considered, but which type?
Crohn's disease?
Yeah, Crohn's disease, because remember, ulcerative colitis, remember colon, right? Is there just in the colon, and Crohn's disease can happen from the mouth all the way to the anus, right?
And can I also consider carcinoid tumors?
Consider what?
Carcinoid tumors.
It's possible that you could consider carcinoid tumors, because carcinoid tumors are part of that GI tract set of tumors, right? Or within the area or anatomical area where tumors can come from. But the problem is that it would have like a different set of symptoms, right? It would have a different set of symptoms with it, and not really specifically, or rather broadly, abdominal pains or vomiting. Yeah. Any other questions?